granular cell tumor, and neurofibroma. Salivary type tumors such as pleomorphic adenoma, benign epithelial odontogenic tumors such as amyloblastoma, benign mixed epithelial and mesenchymal odontogenic tumors such as ameloblastic fibroma, benign mesenchymal odontogenic tumors such as odontogenic fibroma and cementoblastoma, and so on. Malignant tumors include squamous cell carcinoma, salivary type tumors such as mucoepidermal carcinoma and adenoid cystic carcinoma, odontogenic carcinoma such as ameloblastic carcinoma, odontogenic carcinoma, odontogenic sarcoma, and so on. Cyst in the oral maxillofacial region includes odontogenic cysts of inflammatory origin, such as radicular cyst, odontogenic and non-odontogenic developmental cyst, such as dentigerous cyst, odontogenic keratocyst, calcifying odontogenic cyst, nasopalatine duct cyst, and so on. This is my topic today. First, I'm going to talk about oral cancer. Current situation of oral cancer in Japan, guideline of oral cancer treatment according to Japan Society of Oral Tumors, and introduction of oral cancer in our department. Second is about our strategy for odontogenic tumor and cyst in oral and maxillofacial region. This graph shows trends include mortality rate for leading cause of death from 1947 to 2013 in Japan. After the end of the World War II, the mortality of infectious disease such as tuberculosis and pneumonia are decreased, while the mortality of lifestyle disease such as cancer and heart disease are increased. Cancer has been the leading cause of death since 1981, according for 30% of all deaths recently. This graph shows cancer incidence of Japan in 2015. Digestive cancer such as stomach, colon, and rectum cancer is most common in Japan. Colon and rectum cancer is seen in 14.4% of all, and then lung cancer is seen in 14.2%, and stomach cancer is seen in 14.1%. Mouth and pharynx cancer is seen in about 2% of all. You can see the number of patients in head and neck cancer in Japan in this graph. Oral cancer is most frequent site of head and neck region, according for 27% of all. Age distribution of oral cancer by gender is shown in this slide. It indicates that the number of male is larger than that of female between 10s and 70s. The peak is 60s for male and in 70s for female respectively. And over 80, female patients are larger than male patients. It is considered to be more long living of female than male. This slide shows distribution of subsite. It's the most affected region, according for 54% of all, and followed by lower gingiva 15%, upper gingiva, floor of mouth, the buccal mucosa is 9% each. This slide shows T and N status. Almost half of the patients are T1N0 and T2N0 cases. But still, the stage 4 cases are seen in 13.7% of all the patients. Next, I'm going to explain oral cancer treatment in Japan. This guideline is accepted by Japan Society of Oral Tumors. This slide shows T1N0 and T2N0 cases. In these cases, surgery or radiation therapy may be used. Usually, surgery is the first choice, and radiation therapy, such as implant radiation therapy, is also selected depending on institution. In addition to primary resection, elective neck dissection may be considered. If the node is pathologically positive, adjuvant therapy may be followed. This slide shows T3 or T4N0 cases. The patients will receive primary resection with elective neck dissection and reconstruction surgery if necessary. Chemoradiotherapy is also one of choice, and then in case the tumor remains after chemotherapy, surgery is performed. This slide shows T1 or T2 or T3 and N1 or N2 cases. Surgery with neck dissection is performed in these cases. Reconstruction surgery is performed as needed. Neoadjuvant therapy and adjuvant therapy are performed as necessary. In T4A and N1 or N2 patients, the upper part of treatment is same. Here is same with previous slide. After receiving chemoradiotherapy with super-selective intra-arterial chemotherapy, if the primary lesion diminished completely, but neck metastasis is remained positive, patients will receive neck dissection. If the primary lesion is still remained, salvage operation and neck dissection will be performed. This slide shows T4B NET and NET N3 cases. In these cases, best supportive care is recommended. Chemoradiotherapy may be used as downstaging treatment. If primary tumor will reduce after chemoradiotherapy, salvage operation might be performed. Next, I'm going to talk about introduction of oral cancer patients in our department. Hokkaido University Hospital has 944 beds now. We share 26 beds among them. About 2,500 new outpatients visit our department every year. The number of oral cancer patients is about 40 in a year. This means about 1.5% of all. This graph shows the number of oral cancer patients from 2004 to 2013. Total number is 298 patients. Male are 163 and female are 135. The number of male patients is larger than that of female. And the peak of patients is in 60s for female and in 70s for female. Respectively, it indicates that our data is similar to current situation in Japan. This chart shows pathological diagnosis of primary site. Squamous cell carcinoma is the most common diagnosis, and it accounts for 77% of all. And others were malignant lymphoma, sarcoma, salivary carcinoma, and so on. This slide shows distribution of subsite in our department. Tongue is 36% of all, and followed by lower gingiva 18%, buccal mucosa is 15%, upper gingiva is 12%, and floor mouth 9%. I guess the reason why this percentage is different from the above mentioned percentage of Japan Society of Head and Neck Cancer is that the patient with gingival cancer have a tendency to visit dentist than ENT doctor. This slide shows T and N status. The number of the patients with early stage and advanced stage is almost same. Stage 1 is 15,6 cases. Stage 2 is 68 cases. Stage 3 is 33 cases. And stage 4 is 67 cases. And next, I'd like to share with you my experience to treat oral cancer in our department. When patients with oral cancer visit our department, they receive the examination for assessment of systemic problems by blood test, electrocardiogram, spirometer, and so on. Image analysis includes computed tomography, ultrasonography, magnetic resonance imaging, are performed for assessment of primary and regional lymph node metastasis. From panoramic X-ray and bone CT, we could find their invasion pattern. From enhanced CT, we could find their metastasis to the regional lymph node. From MRI, we could find their invasion to surrounding soft tissues. FDG positron emission tomography is also performed to find other cancer in whole body, because many papers say that 5 to 8% of oral cancer patients have other cancers simultaneously. After pathological diagnosis by biopsy, patients are referred to the hospital cancer board. In this board, not only oral maxillofacial surgery doctors, but also ENT doctors, medical oncologists, and radiation oncologists attend. Then clinical diagnosis and treatment plan is discussed and decided. After hospitalization, we share the information of the patient between other doctors, nurse, and patient's family. We also explain all of the details of post-operative dysfunction such as speech, swallowing, and aesthetic problems. We consider the most important adverse effect of the surgery is swallowing dysfunction. Usually, swallowing is reflex motion, so nobody pay much attention to this movement. The patient is instructed the swallowing exercise before operation with imaging the conditions after operation. This exercise helps surgeons and patients and also their family who support the patients. Patients also meet the anesthesiologist for their tolerability to severe operation. Here I'm going to describe the outline of the rehabilitation program for post-operative swallowing dysfunction in our department. We perform oral cleaning and dental consultation initially, and we assess pre-operative swallowing function. Pre-operative video fluoroscopic evaluation is useful to know details of the basic swallowing function of the patient. 1 to 2 weeks before surgery, we provide counseling for patient and patient's family. This counseling is based on video fluoroscopic and or video endoscopic assessments. We also initiate pre-operative exercise for swallowing function at this time. We instruct the pre-operative exercise to the patients and tell them to resume this exercise immediately after surgery and continue during the whole period of the treatment. In a hospital, plastic surgeons do anastomosis and reconstruction. So we have conference with plastic surgeons before surgery. We discuss with them the detail of the operation procedures, primary defect, how to reconstruct it. In this picture, the model shows carcinoma of the lower gingiva. To save the operation time, we make the 3D model by 3D printer. We do the model surgery on this 3D model because to restore the proper relation of segmental bone, especially the condyle head. The resected site is filled by the impression paste, which is a template for the bone of the fibula flap. After resection, the template is confirmed their angle and the length. The removal fibula flap is cut and adjusted to the template. Then fibula is fixed with osteosynthetic plate and screw. This slide shows the events after operation. After removal of drainage at wound site and tracheal tube, rehabilitation will start. We, OMS doctors, also take charge of swallowing rehabilitation. Patients also visit the physical therapist to do rehabilitation for mobility of neck and upper arm. After surgery, we assess post-operative swallowing function and initiate the rehabilitation to improve oropharyngeal function as soon as possible. We perform VF again to assess their swallowing function after initial rehabilitation. We can see the swallowing function was sufficiently recovered 4 weeks after surgery. This patient was CT3 and 0 tongue carcinoma and underwent neck dissection, subtotal glossectomy, and reconstruction with array flap. The left side's video shows his video fluoroscopic image 3 weeks after surgery. There are no aspiration or penetration, but oral transit time was extended, and there was some remaining leakage in oral and pharyngeal space. Right side video shows that image 4 weeks after surgery. We can see his swallowing is improved in only 1 week. Before the time of discharge, this is very important point. Dietitian provide nutritional counseling. And the criteria for discharge is following. Patient will discharge with no infection, no tube, no recurrence, and no additional treatment. Patients with advanced cases, which include the resection of the base of the tongue, sometimes receive the percutaneous endoscopic gastrostomy too. Follow-up intervals are like this. In our department, most of recurrence or metastasis will occur within 2 years after operation. So image analysis is also performed regularly in this period. Patients are referred to the prosthodontist to have dentures. We see the patient not only for detecting recurrence or metastasis, but also monitoring their body weight and food consistency of current eating. Periodical evaluation of swallowing is also necessary. In addition, we consider the final goal of the rehabilitation of mandibular reconstruction with autologous bone flap is the dental prosthetic rehabilitation. More than 1 year after cancer resection and reconstruction surgery, we remove titanium plate and perform vestibuloplasty with flap deflating in the oral cavity to create a buccal and lingual sulcus as pre-prosthetic surgery. Of course, prior to performing vestibuloplasty, the absence of cancer recurrence and healing of the grafted bone should be confirmed. We assess the swallowing function with and without denture using barium liquid, barium paste, and barium pancake. Pharyngeal transit time in swallowing pancake is significantly decreased by wearing dentures. Residue in oral and pharyngeal space were less in the conditions with denture than in these without denture. These results suggest that wearing denture have a significant effect on swallowing function in the patient undergoing mandibular reconstruction. In conclusion, I'd like to say that a consecutive rehabilitation program for oral cancer patients is crucial for overcoming the swallowing dysfunction. There are some important points at each phase, not only post-operative but also pre-operation. Additionally, to provide a denture have a significant effect on swallowing function in the patient who received mandibular reconstruction. I think there are many things to do for the cancer patient as a dentist. Let's move on to the next topic. I'd like to talk about the application of the dredging method for the treatment of odontogenic tumor and large cyst of the jaw, especially for amyloblastoma. I'll be focusing on three basic points. First, the treatment and recurrence rate of amyloblastoma. Second, our approach to amyloblastoma, the dredging method. And finally, case reports treated by the dredging method. Here is a brief introduction. As you know, the main treatment is still wide resection due to the aggressive potential of this pathology for local invasion and high recurrence rate when improperly treated. Numerous complications are seen, such as loss of jawbone support deformity, dysfunction, and psychological distress even after reconstruction. To avoid these complications, a preference has recently been seen for conservative procedures. However, these procedures show a high recurrence rate. We therefore established the dredging method in 1973. So now I will introduce the dredging method and illustrate the key points with some cases. According to this study by Maclay, the recurrence rate with conservative surgery is 65% compared to 11% with radical surgery. As I mentioned earlier, recurrence is a major issue for conservative surgery. Here is our data. The recurrence rate with the dredging method is 19%, much lower than that with other conservative surgeries. So why is the recurrence rate with the dredging method so low? You'll find the answer in this presentation. Here, I will outline the dredging method. This method was established in 1973 by Professor Emeritus Kawamura and consists of four steps: deflation, enucleation, and repeated dredging and follow-up. This method has two main important purposes: to eradicate the tumor and to restore the normal form and function of the jaw. We have applied this method to almost all ameloblastomas we have seen since 1973. I will give you more information regarding each step on this next slide. The first step is deflation. The purpose of this step is to release an intracytic pressure and facilitate the formation of clear bony outline. We remove a part of the tumor wall and any overlying bone. At the same time, we perform biopsy to make a diagnosis. This case is another case. For huge amyloblastoma, we do deflate at two portions of the tumor. This is bony window here. Sometimes we make two windows. About 3 months after deflation, the volume of the tumor is reduced and new bone has formed to surround the tumor. Then we move on to step 2, aniculation. In this step, we remove the tumor completely and also the surrounding newly formed bone at the same time. Here, I need to emphasize that even if the tumor and surrounding newly formed bone are removed, tumor cells may remain in newly formed bone. About 3 months after enucleation, scar tissue has formed on the bone surface. Here. We cut the wound again, then reflect the mucoperiosteum and remove all of the tumor. We also remove the surface of the newly formed bone to check by histopathology. Finally, the wound is kept open again. Here we made two bone windows. About 3 months after enucleation, scar tissue has formed on the bone surface. As you know, scar tissue retards bone formation. At this time, we move on step 3, dredging. This step has two important purposes. One is removing the residual tumor, and another is accelerating the new bone formation, which I will talk in next slides. To remove the tumors completely, the skull tissues and surrounding newly formed bone are also removed. This step is repeated until no tumor is identified in the removed tissues from 2 consecutive dredgings in histopathology. Complete removal of the residual tumors would obviously help to reduce the recurrence rate. Another purpose is accelerating the new bone formation. Scar tissues which inhibit the new bone formation should be removed. This step is repeated until the bony cavity has been filled out with the newly formed bone. Accelerating bone formation acts to restore the normal form and function of the jaw. The final step is follow-up. Actually, this step is the most important step for the dredging method. We check on recurrence by panoramic X-ray. If we suspect recurrence from a panoramic X-ray, a CT examination is performed. Continuous and regular follow-up is important to identify recurrence as small lesions on X-ray before they can get large. I'd like to show you two case reports. This is case 1. The region is located in the anterior region of the mandible. Dredging has been repeated 4 times to date, at about once every 3 months. Tumor cells were found in the second dredging, but have not seen since. Please look at image 3 here. The bone frame has recovered to almost the original state compared to the initial visit. Now please look at image 5 here. No recurrence has been seen for 3 years. This is case 2. The lesion is located in the right posterior region in the mandible. Dredging has been repeated 3 times to date, at about once every 3 months. No tumor cells have been found since the first dredging. Please look at image 3 here. The bone frame has recovered to almost the original state compared to the initial visit. Now, please look at image 4. No recurrence has been seen for 3 years. In conclusion, the dredging method enables us to preserve the mandibular morphology and oral function, and reduce the recurrence rate compared with other conservative surgeries. Of course, this method is applicable to other odontogenic tumor and large cysts of the jaw. Next, I'd like to talk about tooth preservation in the dredging method. In almost all research, the teeth related to amyloblastoma have been extracted. However, recently, we have tried to preserve the tooth related to the tumor to preserve the oral function. 25 primary amyloblastomas in the mandible that were treated between 1983 to 2010 and followed for more than 5 years. Radiographic images indicated that a total of 67 teeth were related to the tumors. Basically, we preserve the teeth related to the tumor, but following teeth should be extracted. 1. We extract impacted third molar. Following teeth are also extracted during dredging procedure. 2. The tumor exists in the lingual side of the roots. 3. Even if the teeth erupted, normal occlusion cannot be expected because of inclination or erupted in lower position, and so on. 4. The tumor remains repeatedly around the teeth root. We divided these teeth into two types. One is divided type and another is root included attaching type. Involved type is the tooth involved in the tumor, and root include attaching type is tooth with roots included in or attaching to the tumor. This is involved type. 78.3% of this type was third molar. All of them were extracted. 3 teeth of this type were preserved without treatment. This slide shows root included attaching type. About half of this type were first and second molars. 3 teeth were preserved by apicoectomy, and 36 teeth were preserved without any treatment. In these 25 cases, the recurrence rate with the dredging method is 20%, even though we preserve the teeth. This is the result. Recurrences occurred in 3 of the 42 preserved teeth and 2 of the 25 extracted teeth. Between the both groups, there is no significant difference in recurrence. In conclusion, the dredging method enables us to preserve not only the jaws, but also the teeth related to the tumor. Thank you for your kind attention.
Thank you very much.
Thank you.
Dr. Curry, for your amazing presentation. Thank you very much. So the presentation talk about the oral neoplasia and oral cyst management in Hokkaido University. So the things is that we can see from your presentation that the most common oral neoplasia is squamous cell carcinoma, about 77%, and the location is in the tongue, about 36%. And you also introduced us about the swallowing exercise before and after the operation to improve the quality, quality of life from the patient. And from the oral cyst, you mainly talk about the amyloblastoma, and you introduce us about the dredging method. There is a 4-step in your department, like deflation, enucleation, dredging, and follow-up. So both of the case show that both of the methods show that your treatment, your management in Hokkaido University can preserve the mandibular morphology and the tooth, and also preserve the tooth. So I think it's very valuable. How can I say? Very valuable knowledge for us in here, and to share with our undergraduate student, and also oral and maxillofacial resident, also from the oral medicine residents. So I would like to open the discussion session. So maybe there is some question from the students, from undergraduate, from residents of oral maxillofacial surgery, or resident from oral medicine, or maybe from Prof. David. Maybe I would like to open the three first question first.
Dr. Suban, can I have a question?
Yes, please, Dr. Isnu.
Good morning.
Briefly introduce yourself.
Oh yeah, good morning. I am Isnu. I am oral and maxillofacial resident, surgery resident. We're very happy to have your presentation in Erlangga University of Dentistry. I would ask about besides clinical and radiographic evaluation in your all of your cases, are there other parameters such as specific tumor markers that are examined to determine the prognosis or potential recurrence of your case before dredging therapy? Thank you.
So before you answer the question, Dr. Kuri, I would like to confirm the question. So Dr. Isnu, you asked about the tumor marker, right?
Yes.
Before the operation or after the operation?
Before we take operation, we usually take a biopsy, and
that's right.
Maybe there is some specific tumor marker that examine from your center to get truly option about dredging or another therapy.
Okay, Dr. Kri. So the question is, after the biopsy or before the operation, or what when you check the histopathologic from the biopsy specimen, did you check also the tumor marker specific to the related to the treatment, maybe?
Tumor marker with immunohistochemistry,
but
Yes,
not
Prof.
from the blood.
I think we can make diagnosis amyloblastoma with only HE staining.
Okay.
Mm-hmm.
So
but sometimes it
after the H.
Yes.
Hi.
Hmm?
So after so after you perform the HE staining, and you can see the morphology, histopathologic morphology from the biopsy specimen. Do you perform immunohistochemistry for tumor marker or no?
Sometimes, but I don't know the details because yes, another doctor.
Okay. So I think the answer is that there is no the diagnosis will be completed after the HE staining, and we can see the morphologic histopathological morphology, and we can diagnose the tumor. But sometimes also Dr. Kri and her team also perform the immunohistochemistry to perform the tumor marker, but she don't know about the exact treatment, examination because other
Oral
department will perform that.
pathologist.
Yeah,
make
oral
that
pathology
diagnosis, yes.
will perform that. So the oral maxillofacial surgery will receive only the histopathological examination, right?
Yes.
Yes, that's right. So how about that, Dr. Isno?
Oh, so there is
Thank you.
no still not
Thank you
finished
for
yet.
the answer.
So Dr. Kuri, I will mix sometimes with English and bahasa, so I'm sorry. So mungkin Dr. Isno pemeriksaannya itu hanya sampai di morfologi HPA ya, morfologi histopatologi. Kemudian untuk pemeriksaan tumor markernya itu sepertinya by request ya, by request kalau memang perlu gitu ya, atau karena Dr. Kuri adalah dari bedah mulutnya gitu ya, bukan dari oral patologisnya, oral patobiologinya, sehingga yang diperlukan oleh bedah mulutnya mungkin hanya sampai ini diagnosa HPA-nya apa gitu ya. Ketika nanti mungkin untuk tumor markernya mungkin untuk penelitian atau mungkin untuk keperluan lain mungkin bisa seperti yang beliau tadi bilang adalah sometimes gitu ya, sometimes they check, sometimes they not, mungkin related pada penelitian. Tapi bukan suatu yang rutin sepertinya ya. Begitu ya Prof. David ya sepertinya ya.
Ya. Jadi memang pemeriksaan tumor marker, maybe I better speak in English. The tumor marker examinations, as we have learned from the literature, can help the surgeons to confirm whether it is aggressive or less aggressive kind of tumor. So we can know more about the biology features of the lesions. Yeah. So in the literature, there are many kind of tumor markers that they examine with immunohistochemistry, and from that, the pathologists can help the surgeons about whether to resect or to do more conservative surgery. I hope that this is what Isnu would like to have the answer. But from your answer, it is not performed regularly in your department, so it is by request. Yeah.
Yes.
Thank you, Prof. David, Dr.
Thank you, Prof.
Supri,
David.
and
Yes.
Dr. Kazio.
Dr. Kuri. Okay, thank you very much. That's a first question from the oral maxillofacial surgery residents. So is there another questions from the audience? I hope there is a question from undergraduate student.
Good afternoon, Dr. Subhan.
Okay, Dr.
Want to ask a
Andreas.
question. Okay, thank you.
You know Dr. Andreas, right?
Yes.
Still remember me, Sensei.
Yes, of course.
Okay, please, Dr. Andreas.
Okay, thank you
But
very
also,
much.
please introduce yourself briefly.
Okay, good afternoon, Dr. Kuri Bayashi and another fellow participant and senior. My name is Andreas. I'm from Oral and Maxillofacial Surgery resident in Erlangga University. First of all, I want to say hello to Dr. Kuri Bayashi. I want to ask some questions, Sensei.
Yes.
My first question is about chemotherapy. In your department, you are using a lot of regimen of chemotherapy, I think. But I want to ask about, are you using neoadjuvant therapy also? And I think in your department, and what kind of usual regimen that you use? And the second question, the second question is about the dredging method. Is it applicable to any type of amyloblastoma? Because amyloblastoma is usually, especially I think, is for mural type and solid type. Is it applicable to use on a very large amyloblastoma with infiltration to the bone? And I mean expansion with a huge expansion. Yes, this is the question. Thank you very much.
Thank you very much, Dr. Andreas. Please, Dr. Kuribayashi, if you get the, can you understand the question?
Yes.
Okay, please. Please.
First question. Our regimen for neoadjuvant chemoradiotherapy. I'm searching the slides.
Oh yeah, you can share.
Can I
again.
share?
Yes, yes.
Please wait.
Okay. So now Dr. Kuri will try to show the slide of the protocol treatment, I think, because the previous slide, Dr. Kuri showed the neoadjuvant therapy for chemotherapy. So please wait for a minute.
This is our regimen for neoadjuvant chemoradiotherapy. We use docetaxel and cisplatin.
Docetaxel and proxylatin.
Yes. Once a week, we inject docetaxel, and cisplatin is injected every each radiation, and total radiation is 39.6 gray.
Slide-nya belum muncul ya.
Dr. Kuri, can you show your slide again about that neoadjuvant therapy, or you only explain?
This slide, is this slide acceptable?
We haven't seen the slide. Sorry, Dr. Kuri, maybe.
Oh.
Need to
Sorry,
share.
do you?
Okay. So
You don't.
No, I cannot see the slide. I'm sorry.
Sorry. sorry. Okay. Oh.
Okay. Okay, I think we can see the slide.
Let's see. Can you see?
Yes,
Sorry.
you can see.
Okay. We use docetaxel once a week.
Yes, DOC. Okay.
Yes, maybe 4 or 5 times in the period of the neoadjuvant chemoradiotherapy. And cisplatin is used every radiation. The total is here, and radiation is 39.6 gray totally before operation.
Jadi tampaknya kombinasi ya antara kemo radiasi ya. Neoadjuvant chemoradiation.
This is effect of chemoradiotherapy. The tumor is became very small. Sorry. Can you see?
Yes, we can see before chemoradiation therapy and after the before surgery.
Yes,
after
before
the
surgery.
Yes. Yes, we can see the photo.
He underwent surgery after this.
After the tumor becomes smaller, right?
Yes.
Ya,
Oke.
Undergrad dijelaskan Dr. Suban kira-kira apa?
Oke, ya.
Bagaimana ya?
Ini untuk I'm sorry, Dr. Kuri,
Yes.
I will talk in bahasa. So untuk undergraduate student untuk mahasiswa ya S1. Jadi ini yang ditanyakan Dr. Andreas tadi itu adalah regimen untuk neoadjuvant terapi gitu ya, sebelum operasi. Ya, koneksinya bisa, mahasiswa bisa dengar nggak ya? Koneksinya sepertinya agak terputus tadi. Oke, bisa? Ya, oke. Jadi sesuai dengan yang stadium tadi ya, ada dijelaskan tadi di awal stadium 1, stadium 2, 3, dan 4, ada early stage dan late stage tadi. Nah, kalau di early stage, mereka langsung ke operasi. Kalau yang di late stage, di stadium 3 dan stadium 4, ada protokol namanya neoadjuvant terapi atau neoadjuvant kemoterapi atau neoadjuvant chemoradioterapi gitu ya. Jadi tumornya itu karena sudah T3 stadium 3 atau stadium 3 stadium 4 gitu ya, besar gitu ya. Sudah di late phase gitu ya, sehingga perlu dilakukan kemoterapi atau chemoradioterapi gitu ya, untuk membuat dia menjadi agak lebih kecil sehingga dia menjadi kasus yang operable, bisa dioperasi. Begitu ya. Tadi ditunjukkan fotonya ada lesi mungkin SCC itu ya, saya kurang paham juga. Tadi tidak disebutkan diagnosanya apa. Diberikan chemoradioterapi, lalu mengecil, baru dioperasi. Begitu kurang lebih. Betul Prof? Ada tambahan?
Iya,
Prof.
betul.
David?
Jadi terapi neoadjuvan itu untuk mengecilkan tumor yang terlalu besar supaya bisa diturunkan stage-nya, stadium T-nya bisa lebih kecil sehingga bisa dioperasi. Kalau terlalu besar, operasinya akan sangat mutilasi. Jadi mengecilkan di depan sebelum operasi itu namanya neoadjuvan. Kalau dilakukannya kemoterapi dan radioterapi setelah operasi namanya adjuvan terapi. Jadi ini tergantung case-nya. Ya, saya kira cukup ya.
Baik.
Kita sampai kapan ya?
Terima kasih Prof. David.
Gimana?
Baik. Okay. Dr. Kuri, the next question from Dr. Andreas was dredging method for is it applicable for any type of amyloblastoma? Because we understand that there is many type of amyloblastoma.
No, sometimes no, because it is easy to apply the cystic type amyloblastoma is easier than another type. So once we make bony window, and tumor cells sometimes grow up outside the mandibular bone. So, but in that case, we perform aniculation first.
Okay.
Yes.
So, Dr. Andre, the answer is maybe not. I think not applicable for any type of amyloblastoma. That's right, Dr. Kuri?
Yes, deflation is sometimes difficult, but almost all type is applicable for aniculation and dredging.
Thank you, Sensei.
Okay.
What about the amyloblastoma with mostly solid and mixed lesion, like especially desmoplastic type? Is it applicable to use dredging on this kind of
we
type?
also perform the dredging method.
Okay. Okay.
Yeah. Okay.
And this maybe one last question, Dr. Subhan. Can I ask one last question?
Yeah. Sure.
Yes.
Sure.
Before this, I was asking about the neoadjuvant. For now, I want to ask about adjuvant therapy. As Prof. David say, about adjuvant therapy is given after the surgery. In your department, in Japan especially, have you already used targeting therapy for adjuvant therapy, such like EGFR inhibitor, epidermal growth factor receptor inhibitor? Have you already used a targeting therapy? The drug is usually, the name is Cetuximab, I think, or something like that. Have you already used targeting therapy? This is the main question. Okay.
So please, Dr.
Sorry, I can't hear you clearly.
Okay.
Oh, sorry. I will repeat the question maybe.
Slowly, Andreas. Not
okay.
too fast.
In your department in Japan, have you already using a targeting therapy for adjuvant therapy of chemotherapy, such like epidermal growth factor receptor inhibitor or something like targeting therapy drug, I think? Have you already used?
Dr. Subhan, may I help?
Good afternoon, Prof. Nakamura.
Good afternoon, Prof. Nakamura.
Prof.
これが先生。
ありがとうございます。
EGF のセキツマブを使いますかという質問をされてます。分子標的治療。
はい。
それをなんか使いますかっていうようなことを言ってますね。
Sometimes we use, but not in a hospital. Only oncologist, medical oncologist perform the chemotherapy.
Okay.
エナメル上皮に使ってるんです
か？No. 使ってないです。
じゃあ多分エナメル上皮に使ってるかって質問じゃなかったかな。
そうだったんですね。
Thank you very much, Sensei.
We don't perform any chemotherapy for amyloblastoma.
For malignancy, I think my question is for malignancy.
Malignancy, okay.
Yeah.
Only medical oncologist in our department, in our hospital.
Thank you very much, Dr. Kuri, and thank you very much, Prof. Nakamura.
Thank you, Prof. Nakamura.
So the answers, I think, not they don't use that targeting therapy. So I would like to ask. I would like to open the question from undergraduate. Is there any question from undergraduate students? Ayo bertanya. Bahasa Indonesia juga tidak apa.
Izin
Nanti
bertanya.
ditranslate bahasa Jepang oleh Prof. Nakamura.
Tes, izin bertanya.
Ya, silakan, silakan.
Good afternoon. I'm Rahmat Yuliantoro. I'm still only an undergraduate. Thank you about the knowledge. So let me have a little question. Please tell to us why on the stage on deflation we must mix two windows. So just why did that class close of all of that? And would you tell L one more if another steps which will make the patient more comfortable? Thank you.
Okay. Before Dr. Kuri answer the question, saya ulang dulu ya. Jadi pertanyaannya adalah kenapa waktu deflation itu bikinnya 2 windows gitu ya? Itu pertanyaannya ya. Tadi. Betul?
Ada masalah sinyal kelihatannya.
Oke. Rahmat.
Hilang sinyal itu kan.
Oh iya. So, Dr. Kuri,
Yes.
you previously there is a question from undergraduate students.
Mm-hmm.
So, previously you showed the slide of your patient that there is 2 windows.
Yes.
There is 2 windows in the deflation stage. So he asks why you make 2 windows.
The tumor region is very big. That is why.
Okay. So because of the size of the tumor, right?
Yes.
The size of the tumor is very big.
Mm.
Okay, thank you, Dr. Kuri. So Rahmat, jadi jawabannya adalah karena ukuran dari tumornya itu besar, gitu ya, sehingga Windows-nya dibuat 2, gitu. Itu ya, Rahmat ya. Jadi membantu dia deflation-nya, membuat dia lebih kecilnya lebih cepat. Harapannya begitu. Begitu ya. Tadi Rahmat ya yang tanya ya. Yang nggak kelihatan tadi.
Ya,
Okay,
betul.
thank you.
Yeah.
Yeah. So I would like to open one last question. Is there any last question before we end this session?
Yeah. I would like to ask some questions, please.
Okay, please, Dr. Mira. Yes, please.
Okay, thank you. Good afternoon, Dr. Lee. It's very great honor for us to have you here today, as well as Professor Nakamura. Thank you very much. I would like to ask 2 questions. The first is, how long does it take to perform surgery after neoadjuvant therapy? And second question is there potential of malignant transformation after dredging methods? Because in Indonesia, we found several cases after dredging method, they become malignant.
Mm.
Thank you, Dr. Kuri.
The first question is period before surgery after chemoradiotherapy is about 3 weeks. We wait healing of the mucositis. And second question is
Malignant transformation.
Yes, I think sometimes it occurs, but we think the follow-up is very, very important. Sometimes patients drop out follow-up. The patients dropped out the follow-up. I have 2 patients with malignant amyloblastic carcinoma by dredging method, another hospital for more than 10 years. And in that 10 years, that patient didn't visit any hospital. The follow-up is very important, I think.
Yes, thank you, Dr. Kuri. Same as in our clinic, several cases are more than 10 years after dredging method, because they also didn't have any visits to evaluation, so they come when it's already transformed to amyloblastic carcinoma. Thank you very much, Dr. Kuri.
Thank you.
Okay. Thank you very much, Dr. Mira, for the question, and thank you very much, Dr. Kuri, for the answer. So, how about from undergraduate? No? Okay. Thank you very much, Dr. Kuri. So, I would like to make some conclusion about today's lecture from you. So, I would like to do it in Bahasa, so I can share the knowledge to undergraduate students. So, kesimpulan hari ini adalah bahwa saya bukan kesimpulan ya, maksudnya resume sedikit bahwa pengalaman di Hokkaido University menunjukkan bahwa ada kasus neoplasia di rongga mulut yang terbanyak adalah squamous cell carcinoma sekitar 77%. Kemudian ada tim yang menangani untuk oral neoplasia dan oral cyst. Itu banyak tadi disebutkan, ada bedah mulut, ada dokter gigi juga ya. Jangan lupa bahwa dokter giginya akan bertugas untuk cleaning ya. Tadi ada cleaning dan dental konsultasi dental untuk kondisi giginya. Kemudian ada dokter ENT dan fisioterapi juga ya tadi disebutkan. Kemudian untuk perawatannya ada ada neoadjuvan terapi, kemudian ada operasi, ada adjuvan kemoterapi juga. Kemudian untuk di amyloblastoma mereka menggunakan dredging method yang mungkin sepertinya berbeda dengan yang dilakukan dari UNAIR gitu ya. Karena kalau di UNAIR kita akan melakukannya menggunakan reseksi mandibula, karena dredging method seperti yang disebutkan tadi ada kemungkinan menjadi recurrence dan ada kemungkinan menjadi keganasan. Dari situ semoga apa yang disampaikan Dr. Kuri bisa dapat berguna terutama untuk mahasiswa ya, untuk S1, baik itu sebagai pengetahuan, nice to know gitu ya, untuk tahu bahwa oh ini ada oral neoplasia yang harus kita perhatikan. Okay, thank you very much, Dr. Kuri. I think we can end this first session from you. Thank you very much.
Thank you very much.
Is there any comment again from Dr. Mira or Dr. Prof. David?
Thank you, Dr. Kuri. It's very nice to see you again, although it's online meeting. We hope that we can see you in the near future.
Yes.
Face to face. Thank you, Dr. Kuri.
Thank you very much.
I hope we can visit Japan also.
Yes.
So we can visit
yeah.
after the pandemic end.
Yes.
Of course.
Thank you so much.
Thank you very much, Dr. Kuri. Okay. Before we go to the next question, before we continue to the next session from Professor Nakamura, I think we can break about 5 minutes before. Is it okay?
Okay.
Professor Nakamura, can you wait 5 minutes break?
Okay.
You should.
5 minutes later, I start the presentation.
You can start. Yes, you actually start 11:45. But if you have time, we can can make it earlier. Is it okay?
Okay, no problem.
So we can. I think I propose to start the
Ribbon?
presentation like 11:30 Indonesian
Okay.
time.
Yes.
Because after this we can have we will have the praying time. Duhur.
I
Yeah, I'm
also.
sorry. Yeah. Thank you. So break. Okay, we will have a break until 11:30. Please join again at 11:30 Indonesian time.
栗林先生お疲れ様でした。
中村先生、ありがとうございました。
いえいえいえいえ
先生、いつからここに入ってましたか？
僕ですか？あ
何時ぐらい
れが始まってから、クエスチョン、質疑応答始まってから、もっと早く入ればよかったと。
いやいや、もう恥ずかしいです。全然英語できなくって。
皆さんお元気ですか？北海道大学の。
元気です。頑張ってます。九州どうですか？
もう全然コロナいないですよ。
いないんですか？
もうないですね。今入院してるのが全部鹿児島10人ぐらいですかね。
ああ、いいです。それです。行きたい。行きたい。
スバン、奥さんは？
そうです。鹿児島で。
まだ日本に。
はい、鹿児島にいます。
会えないでしょ？
そうですね。会いたい。
ねえ。
寂しい先生。
Iya, ditranslate.
I heard the next month
Rahasia.
our country open to the abroad, right?
Yes, I heard also, Sensei, but we have to quarantine ourselves for 2 weeks in Japan, right?
Yeah.
Your country open,
Yes.
except Indonesian.
先生はよくエランが行かれるんですか？栗林先生、インドネシアに、エランガ大学行かれるんですか？
いや、今年の2月に初めて行きました。
ああ、本当ですか。
はい。
いい人たちですよね。
はい、すごく本当によくしていただいて、
はい。
楽しかったです。
僕も大好きですよ、ここ。
はい、また行きたいです。
よかった。先生が温めてくれたんで、僕は喋りですから。
恥ずかしい、もう本当に。
懐かしい人いっぱいいるんですよ。Professor David.
Yes, Sensei.
Hi. You are from your house?
Yes.
So you stay home still now?
I'm still at home. We are afraid to go out of the house if not necessary. How about in Japan?
Japan.
Not that bad.
Yeah, I think so. The COVID now is shrinking.
Indonesia stable.
Still expanding.
Stable high.
Still high. Still high.
Stably high.
So you have to control. I cannot go there.
No, you cannot. You must not come here.
Don't come.
People in Indonesia very difficult to obey the rules.
Yeah.
Now the regulations, they got fined if they don't.
How about the dentist? Dentists in Surabaya, is it possible to treat the patients?
It is possible. It is possible. They are allowed to practice, but on their own risk.
Yeah, on the risk.
Yeah. So some dentists still don't want to practice at all. Especially the older generations, they don't dare to get exposed to their patients.
But Kagoshima is in a rural area, not a big city. Kagoshima, you know, right?
Yeah.
Kampung kan, Kagoshima. Jadi tidak ada banyak pasien.
Oh.
Maybe Sapporo is more bigger. 札幌のコロナどうだよ？ハーバードコロナ。
10 patients a day or less, maybe.
In
But
hospital,
now much better than before.
Stable.
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 But in Sapporo, it's start colder.
cold.
You
Yeah,
enter
yeah.
the winter season.
There are Suskino.
But now you entered winter. The temperature become cooler.
Yeah, but coronavirus is
Doesn't care the temperature?
I don't know, but
Last time, people said that the coronavirus is more virulent in cold area. But now, I don't think it is true.
Yeah.
Because Indonesia.
Because Indonesia, you have a lot. They're very strong.
Yeah.
So, Sensei, Nihon no vaccine wa do?
どうかな。まだまだよ。The country prepared a vaccine for all nations, but I don't know the effect. アビガン効かないとか効くとか効かないとか言ってるしね。
そうですね。
You know the アビガン？ドクタースバン？ドクタースバン、フリーズとした。
I'm sorry, the connection is not good. I cannot hear your voice. Freeze.
Where is the Muin? I just see pictures.
Hi, imasu. Muin.
Muin.
Please show your voice. Muin.
Sleeping.
Yes, Sensei. Apa kabar?
Baik. Baik saja. Alhamdulillah baik.
Kabar baik. Syukurlah ya, di UNER aman ya. Residence oke ya. Residence oke ya. Data Suban begitu ya.
Ya begitu.
Suban ada masalah signal.
Nakamura Sensei, this is Irma.
Oh, Irma-san. Konnichiwa.
久しぶりです。
気づかなかった。ビューティフルあれだね。
そう、ありがとう。そうですね。
New style.
Just a simple one. Since we are at home. Yeah. Sensei, Professor Darmawan has a class right now, starts from 11. So he really want to join with your class and say hi before you start your class right now. But unfortunately, he cannot postpone the class. So maybe after finish the class, he will join with us and talk to you after your presentation, maybe.
All right. Thank you.
Yeah.
Thank you very much for inviting me to the SOS.
Yeah, I'm really sorry. Maybe you have found many inconvenience about the signal, about the information, because we do in remote mode everything right now. So it is difficult for us to make a coordination directly with our staff, someone.
No
yeah,
problem.
I'm sorry. This is the best that we can do. I hope you can share with us. And thank you very much to Dr. Kuribayashi for your interesting presentation today. I think this is a cold season right now, right? In Hokkaido right now. It's go down.
Temperature is 18 degrees.
18.
Wow.
Is it cold for you?
Yes, I'm a tropical person. 25 is cool for me.
Oh.
Even 25, we wear a thin jacket sometimes. Yeah, it's very interesting. So I hope everybody is fine. Yeah, everybody can prevent the COVID-19. Yeah. Okay, Dr. Suban, thank you very much.
Okay, we start.
Okay. Now we enter the second session. Before we start the second session, I would like to ask Dr. Kuri, you want to still join or no? Is it because I think it's okay for you to
stay here. Can I continue to join?
Okay, thank you very much. Thank you very much.
Thank you.
Yes, thank you very much if you want to join. Thank you very much. Okay, now we enter the second session of this today's event. So the next speaker is Professor Nakamura. I think we already know him very well. He many times came to Indonesia, to Airlangga University, and today he will talk about the comprehensive management of cleft lip and palate and the role of general dentist, I think. So because the main target of this session is undergraduate student, so undergraduate student will have a lecture about the cleft lip and palate. So Professor Nakamura, are you ready for your presentation?
Yes.
Yes. Okay.
Hi, the condition of my voice. It's okay?
Yes, it is okay.
Okay. My voice?
Yes.
Yes, okay.
Right. Thank you,
Voice is
Dr.
okay.
Suban.
Before I'm sorry, Sensei, please, the other participants.
Yeah. Signal.
It's okay? I start. Good morning, everyone.
Yes.
Yes, please start your presentation.
Selamat pagi semua, anak-anak semua dan ibu-ibu, bapak-bapak, saudara-saudari sekalian. Assalamualaikum.
Waalaikumsalam.
Yeah.
Waalaikumsalam.
I'm Noris Nakamura from Kagoshima University, Japan. So first of all, I'd like to express my gratitude to Dr. Darmawan Setianto, the Dean of Dental Faculty at Airlangga University, and Professor Kun Pramono and Professor David Kamajaya from the Department of Oral and Maxillofacial Surgery. It's a great honor to be invited to the SOS Stovit online series program as a visiting professors of the University of Airlangga. So I'd like to meet you directly, actually, and work together again. But because of the COVID-19, so we have to meet on the network. Today's my topic is comprehensive management of cleft lip and palate. So the role of dentists, especially I talk about pre-surgical orthopedic treatment and orthodontic treatment and orthodontic surgery. Okay, I shared the slide. Hi, the slide.
Yes.
You can see?
Yes. Yes, we can see.
See the pictures of the staff of the Airlangga?
Yes.
Very clear.
You can see.
Okay.
Clear.
Okay. First, like ice break. Boleh pakai bahasa Indonesia sedikit nih.
Wah, sangat boleh.
Beberapa tahun yang lalu nih, saya datang ke Surabaya dengan mahasiswa kami dan istri saya, dan kita senang melihat teman-teman yang banyak di UNER. Saya juga menikmati selama untuk para mahasiswa. Waktu ini saya datang ke dengan Dr. Son, mahasiswa internasional dari Korea. Adalah pria yang ganteng, handsome. Jadi kita berfoto dengannya bilang sarang heyo. Sekarang saya rindu sekali, saya tidak bisa pergi ke Surabaya. Dan mudah-mudahan saya sangat berharap Anda sehat dalam COVID-19. Waktu datang ke Erlangen, saya bekerja sama dengan dokter-dokter bedah mulut untuk menutup palatal fistula wanita muda yang cedera bibir dan langit-langit dua sisi. Di New Dental Hospital, kami bekerja sama untuk menutup fistula palatal pakai tongue flap, jaringan lidah. Saya pakai topi yang cocok untuk Profesor Kun. Dan palatal fistula ditutup dengan baik. Setelah operasi ini, saya dapat foto dengan pasien yang tersenyum. Ya. Dia sangat senang sudah diperbaiki masalah dia. Kami berharap situasi ini akan membaik dan kami dapat bekerja sama lagi secepat mungkin. Okay. I think some of you know that I was in Jakarta around 25 years ago. Maybe most of the students have not been born. Right? I joined from Suhati in Harapan Kita Children and Maternity Hospital. Suhati means senyum dan sehat anak Indonesia. This is a photo of the first member of the cleft lip and palate team that was consist of dentist, orthodontist, dentist is the chief, and plastic surgeon, pediatrician, speech therapist, and I, oral surgeon on the back. I was still young. The purpose of the program was to establish a comprehensive treatment of CLP by an integrated team comprised of various specialists. In 1990s, there are many patients who had problem of missing teeth and severe malocclusion related to the cleft lip and palate. The dentists and orthodontists thought that it was very difficult to treat the occlusion at the same level as healthy people. And they thought that the establishment of the comprehensive treatment of cleft lip and palate, CLP, considering the dental-facial growth was necessary. That's why I was invited. When I was in program Suhati, I worked in outpatient clinic to examine the patients speaking Bahasa Indonesia, and we applied hot spray for feeding assistance. I worked in the operating theater, and I operated more than 120 patients during 2 years. I also helped with interdisciplinary management, which connected surgeon and orthodontist and speech therapist. When I started operation in Harapan Kita Hospital, I was surprised to see a patient on the operating bed. She was very wide cleft, and I was troubled by labioplasty in patients with such a wide cleft at first. The slide showed the operation record of this patient. I described the width of the cleft lip was more than 20 millimeters. During the operation, I tried to dissect, pull the lip, but the lip segment did not contact. Finally, I pulled the lips and sutured, but it was very tight. I finished the operation, but 3 days after the operation, the lips start opening. So this is a post-operative view of patients at 5 years of age. So there was scar on the lip and nose deformity remained. After this bad experience, so I asked the orthodontist to control the wide cleft lip by orthopedic effect treatment using a hot spray. The oral operation was taken by dentist just afterwards, and the hot spray was applied almost 1 week later. After using a hot spray for more than 3 months, the wide alveolar cleft became narrower. And finally, I was able to perform labioplasty safely and successfully. Even now, so it was very painful for me to remember those days. So these are the patients I treated at Jakarta, and I asked to recall all patients. They are not perfect, but the shape of the lymph nodes seem to be acceptable. However, I'm very grateful that I was able to overcome the troubles with the support of dentists and orthodontists. So from my lecture today, I hope for you to understand the role of dentists in the treatment of cleft lip and palate. And if you find the correct patient in the future, please help them in your own field. Okay, now I move to the topics, the treatment of cleft lip and palate. On this slide, okay, this slide shows the problem related to the cleft lip and also the cleft palate. As you know, the problem related to cleft lip and cleft palate are different. In cleft lip, aesthetic problems such as lip and nose deformities are most obvious. Furthermore, malocclusion and articulation disorder occurs. If the aesthetic problem is left for a long time, psychosomatic problems may develop. That's very difficult to control. On the other hand, cleft palate has no aesthetic problems, but sucking disorder, speech impairment, and growth disturbance of the maxillas are serious. So the problem of cleft lip and palate are wide range and difficult to solve at once. They are not treated only in operation. It is widely recognized that comprehensive treatment that select treatment method and treatment periods from a long-term perspective, not limited to the immediate problem, is important. That is very important. It is said that team approach is very important. The team for cleft lip and palate include oral surgeon or plastic surgeon, and orthodontist and the speech therapist. They are the fundamental of team cares. Additionally, the prosthodontist, ENT doctor, pediatrician, physiologist, and nurse are included. They can support from the outside. In Kagoshima University, pedodontists and preventive dentists join the team. So these various specialists are integrated for the same purpose to lead patients to the healthy social life without serious problems. Now I introduce my impressive case in Harapan-Kita, and it is one of the instances that we have to recognize and need of comprehensive management. The patient was 8 years old boy with bilateral cleft lip and palate, and he visited hospital with a chief complaint of no teeth in the upper anterior area. He looks very cute, and he had already had 6 surgeries to close the palatal fissura. And then finally, the fissura was closed using a labial mucosal flap. The surgeon focused only on fissura treatment, but he forgot about the tooth eruption. So we found the central incision beneath the labial mucosa. On X-ray examination, all teeth are closed by the labial tissues. In 1996, I exposed the bleed teeth under the mucosa, and orthodontists gradually moved the teeth by orthodontic treatment. and later upper central incisor elapsed in the dental arch. This is after he became an adult, but he suffered from the serious malocclusion due to the maxillary growth disturbance. So you can see concave face. He has the big over anterior crossbite. When palatal fistula remained, if the plastic surgeon consulted the dentist, the eruption of the teeth might be more smooth and better for the maxillary growth. So we have to select the treatment method from the long-term perspective. So we don't think only immediate problem. This is important comprehensive treatment of the cleft lip and palate. Now I show the treatment schedule of comprehensive treatment for cleft patients in the hospital. The feeding assistant and precise orthopedics start at the pre-birth and the birth stage. And the primary lip repair is performed 3 months after birth. And the palate is performed at 1.5 years. If we do the palate area like just after birth, maybe the serious maxillary growth disturbance will occur. So we wait until 1 year or 1.5 years, and then followed by a speech training. Orthodontic management starts at 4 years of age, but during the deciduous teeth stage, we don't touch anymore. And then after eruption of the permanent teeth, the orthodontist start orthodontic treatment. And nowadays, from 8 to 11 years, oral surgeon perform the secondary bone graft in the alveolar cleft, and the orthodontist move the teeth to make a good occlusion. And then 16 or 18 years old, after finish the puberty, and secondary lip and nose correction and orthodontic surgery is performed. Our goal is to guide the patient healthy social life. So for these goals, we support the patient psychosomatically. That is also important. This is a cleft lip and palate clinic in Kagoshima University Hospital. This is located in the corner of the Department of Oral Surgery. Many staff of cleft lip and palate team, like orthodontists, speech therapists, also gather and work together in this clinic. In the room, many words are used to encourage the patient and their parents. Then such, thank you for your birth, or let's smile like a blooming flower. These are the works of our nurses. Now I talk about early management of cleft lip and palate baby. We manage the patient with first counseling of the family. We perform the prenatal counseling, genetic counseling, and then explanation of disease, the state, and then how the patient is treated. And next, feeding instruction using a feeding bottle with a large nipple hole and hot spray, like you call obturator. And the pre-surgical orthopedic treatment for wide cleft lip. And we also use the surgical tape or band-aid to control the separated lip. And then pre-surgical orthopedic using the hot or numb. So this shows the pre-surgical treatment just after birth when the baby comes. Pre-surgical treatment of wide cleft lip using surgical tape is performed. Pre-surgical means before the labioplasty, we control the wide alveolar cleft. We also use band-aid is okay, you can use. By pulling the lip segment with the tape, so lip pressure is restored and a wide open maxillary segment will approach together. For this purpose, we use the 3M micropore surgical tape from birth to labioplasty, almost about for 3 months. Next is hot sprite we performed. The hot is the name of the orthodontist, the dentist in Switzerland. And hot sprite is like obturator for closing the cleft space and helping the baby's feeding. The hot sprite is consists of 2 parts. The white part by heat killing soft resin, and the red part by heat killing hard resin. In Harapankita Hospital, the dentist and nurse take our impression 2 days after birth and then produce the plate using a Ferritex soft resin. This material becomes soft at a body temperature around 36 degrees. And then so the plate can fit easily in the baby's mouth. Hot plate has several benefits, including feeding assistance, to close the cleft space, precise orthopedic effects, and nasal mucosa protection. In patients with cleft palate, tongue always enter the cleft space and irritate the nasal mucosa. And sometimes the ulcer is made. And also the tongue push out the palatal shelves, the maxilla segments. By using the hot plate, the tongue is pushed out from the cleft, so the jawbone improved before surgery. You can see the orthopedic effects of the hot plate. Deformed alveolar bone has already improved by blocking out the space of the future growth in the maxillary arch, or by grinding inner surface of the palate, the maxillary segment gradually moves and then restoring a good shape of the maxilla. Now, when the maxilla is improved, the deformity of the cleft, the lips, and also the nose is improved. So it's very convenient for the surgeons. This is the scenery of taking impression of baby's mouth in Kagoshima University Hospital. Usually the pedodontists collaborate with oral surgeon to make hot plate. And most important during the impression is to avoid the vomit of the milk. We take impression after fasting, 2 hours or more. Sebelum cetak tidak boleh minum dan makan selama at least 2 hours. And then so we in our hospital is more careful than Harapan Kita too. She is a pedodontist taking impression, and then 2 more assistant, he and the nurse hold the head and body. And other 2 assistants stand by for the suction, or a surgeon usually, and then measuring the time, pedodontist. 1, 2, 3, 4, 5. Oh, we take impression with 5 person. So we prepare for the monitor, for the heart rate, and then oxygen and the oxygen monitor, like oxygen saturation monitor. The ambubac is a stator mask for breathing assistance at the urgent airway obstruction and the suction. We make our original tray for baby because ordinary tray for kids tray is too big for a baby's mouth. And the silicone type impression material and timer we prepare. This is a step-by-step procedure for taking impression of baby. Since the silicone type impression material can easily flow into the baby's pharynx, so we must take care not to cause aspiration or airway obstruction. It is most important. First, we apply tray in the trial, and then we adjust the edge of the tray with utility wax. We put the impression material on the tray, but we don't enter the mouth soon. We have to wait because the impression paste is too soft and easily enter the pharynx. We wait about 40 seconds until the impression paste harden and the surface of the paste lose shining. Just before paste harden, we enter tray in the mouth. When the paste flows into the pharynx, the paste is sucked out using the suction. After around 30 seconds, the paste hardens and take out the tray. We have to confirm that there is no remnants in the mouth. We usually use originate impression materials, but it's more cheaper. But we stop using it because some of the originate impression may remain in the oral cavity, and then sometimes we cannot remove the impression taste. So in our experience, we took remain impression taste under the general anesthesia. So we stop using originate. So finally, we check the impression whether the outline of the maxillary segments adequately obtained or not. This is a U cell P and B cell P. The good outlines are already impressed. I demonstrate dental technicians' operation for making hot spray. We prepared a plaster model and closed the created space and the anterior part of the alveolar bone for growth using a putty type silicone. Then we will make wax up, and the black line, this is outline of the hard region. And then we bury the model in the flask and melt out the wax. After that, along this line, we fix the hard region, and then later we fill the soft region and hard curves. This is the final view after polishing the plate. So these steps are the same as creating the dentures. So it is not difficult for us. Recently, the pre-surgical treatment for deformed nose using a NAM, nasal-alveolar molding plate, is trend in the world. The NAM was introduced by Dr. Grayson. He's also the orthodontist at New York University in 1999. The stent fixed at anterior part of the hot plate approach to the top of the nasal dome. By the orthopedic effects, the flattened nose is corrected to the, like a dome shape. I showed you how to make a NAM. The base is hot plate. At the anterior part of the plate, we fix the wire frame first, and then it is covered by the hard region. The tip of the stent has bulb and it's located to the canopy of the nasal dome. In Kagoshima University Hospital, it is managed by the periodontist immediately after birth. But usually we put the hot plate first, and then we wait 1 week. And after the baby accepts the hot plate, we start the NAM. So usually 2 weeks or 3 weeks after birth, we start the molding of the nose, correction of the nose by using the NAM. we favor to apply the double peak stent. One push the nostril skin upward, and then another push up that transition area between the upper and lower lateral cartilage, because the nose form is controlled by the lower lateral cartilage. I think it's not complicated for the dentist to manage now, because all parts are made by dental materials. And the complication of NAM is like ulcer. Sometimes inside the nose, the hard resin irritate the surface of the mucosa. That's cause like ulcer. So at the time we have to loosen, release the attachment of the stent to the nasal mucosa. You can see the process of the surgical treatment using the NAM. Several benefits has expected from using the NAM, but just before and after using the NAM for 3 months. The columella base, that's recovered in the midline of the face, and the nasal tip also. So deviation of the nasal tip and columella are improved with the NAM. And another one is extension of the columella length. Before using the NAM, the skin of the columella is very short, and then so with the NAM, the columella length is expanded, and the improvement of dome shape of nasal alveoli. The baby's cartilage is very soft and easily improve the deformity of the nose. You can see the three-dimensional facial forms before and after using NAM. You can see the line connecting the peak of the nasal tip and columella. This line was inclined before using the NAM. And then also you can see there was the big gap of the height between the right and left upper lip and also buccally area. And then after using the NAM treatment, the nasal tip and columella moved toward the facial midline, and the gap of the height of the upper lip and chip was successfully reduced. No serious gap like before the using NAM. That means that the base of the skeletal bone has already improved. The gap of the skeletal bone is already improved using like a NAM treatment. Now, after that, we perform the primary labioplasty. There are several techniques for labioplasty, but we like to use the triangular flap method by cloning techniques. The cloning techniques is characterized by triangular flap 1 millimeter above the cupid peak to produce a natural shape of the upper lip. The size of the calculated triangular flap is calculated from the gap of the healthy side and corrected size. And then it is more reproducible, and then it's more easier to teach to the young generations. For the nasal correction at the primary lip ears, the oral vestibular incision is extended into the nasal vestibule. From the vestibular incision, all lip and nose component can be advanced upwardly. With these procedures, nasal cartilage is repositioned in adequate form. Then the defect in the nasal vestibule is covered using a cleft margin flap, this one. This is cleft margin flap, and then that's fill the defects of the epithelium. Thus, it prevents the relapse of the nether tissues. This is a patient with unilateral incomplete cleft lip. This patient also used NAM before the operation. So you can see the post-operative view without serious deformity and scar on the lip. This technique, in this techniques, the surgical scar is seen along the anatomical subunit of the philtrum bridge, and we perform the overlap suture of the auricularis muscle that produce the natural shape of the upper philtrum. So there's no serious depression of the upper lip here. This is the patient with a very wide, complete UCLP. And the wide cleft was controlled by the pre-surgical orthopedic treatment. And then in this case, so there's a deformity was serious, and then cleft was very wide. So we used the NAM for 6 months before operation. Then after improving deformity, we performed the first primary labioplasty and then a nose correction. And then post-operatively, the lip and nose form was not complete, but still the alar form is smaller than the opposite side, but lip form is quite nice. And then she is 14 years old. And then so I met her last week, and she said she has no trouble in the school. And it's very nice to see her smile with a peace sign. I allowed her to use the slide in this online lectures. For BCF, bilateral cleft lip plate, also we use the NAM surgical orthopedics. And in the bilateral case, we sometimes has trouble or protruded premaxilla using maxilla. And then in this case, the upper lip is here and here. It's very far. It's very difficult to control and to suture during the primary operation. So as possible, we use a NAM to control the premaxilla. Actually, this patient and this patient is different, but like this. In the bilateral case, the NAM has pressed the nasal cavity in the bilateral size, and then upper lip, like a prolabin, is pressed by the elastics. We hold the base of the upper lip and then push up. So we extend the columnar length. And also with these elastics, so we can control the protruded premaxilla. I show the case. This patient had complete BCLP and he was treated by one-stage surgery because we adopt one stage or two-stage surgery. And then in this case, premaxilla was dislocated and the columella was very short. And the pre-surgical orthopedics using NAM was performed for 3 months. The lights show the 6 months post-operative view. Symmetrical lip and nose are restored. And then he is now 5 years old, but almost lip and nose still, the well-balanced lip and nose are recovered. But still, the upper lip is like a bulky because all the position of the premaxilla is a little bit outside of the dental arch. In the future, the orthodontist control the position of the premaxilla. But this is a little bit different from techniques of the labioplasty in the BCLP and between the Kagoshima University and the Elanga University. The Kagoshima University sometimes use the two-stage operation for a patient with bilateral cleft lip. with a very small premaxilla, prolabbium. In this case also, it's very difficult to control the symmetrical lip. We perform the two-stage lip repairs. First, we close one side to make a tentative neural cleft lip condition, and later we close the opposite side. But usually we perform 3 or 4 months after birth, and then second operation is performed 7 months after. Now we wait 3 or 4 months to soften the scar first. And then post-operatively, the balance of lip and nose is, it's okay. And then lip scar is not conspicuous. He start to go to school. The Japanese children become more black, like a heat up by sunburn. And then he likes football, so he always play in the outside. He's now 14 years old, right? But we can see the scar on the lip, but from the outside, we cannot see. Nobody knows he has such a bilateral cleft lip. In the future, we have to improve the form of the vermilion. I think the nose form is quite nice. Like this case is complete UCLP treated by two-stage surgery. Just after birth, the premaxilla was also deviated and protruded. And then we use the NAM, extend the prolabial tissues, and we perform the two-stage lip repairs and 2 years post-operative view. And she's now 10 years old. You can see the small scar on the lip. And then, but the balance of the lip and nose is quite acceptable. And in case of this LP, the nose forms after our primary lip repair is still flat. So the future secondary correction is necessary. Okay, now I'm moved to the topics of the orthodontic treatment. I'm not an orthodontist, but I talk about the orthodontic treatment for cleft lip and palate patients. The patient with cleft lip and palate has several occlusal problems, like a congenital missing of the tooth adjacent to the alveolar cleft. Number of the tooth and the form of the tooth is not same as the healthy children. A rotation of the upper incisor, the crossbite by alveolar collapse, and also crossbite by serious maxillary growth deficiency disturbance. First, I talk about congenital missing of tooth. This is a table. This table showed a percentage of congenital missing, hypoplasia, and normal tooth in AUCLP and BCLA, Just in the digestive stage, congenital missing is recognized only 13 to 17%. Most of the teeth, 80%, is normal. However, when the permanent teeth erupt, the congenital missing is found around 50%, and hypoplasia is around 40%. And the normal teeth are only 6 to 8% in both UCLP and BCLP patients. So the dental problems are not serious in the childhood, but it appears and becomes serious after the school age. This is crowding. The rotation of the upper central incisor. And then this is interfered to the lower incisor. Since the width of the permanent tooth is larger than deciduous teeth, So the upper central incisors are often elapsed with a great rotation because the alveolar bone is not sufficient. And then upper lateral incisor is often missing or hyperplasia. Next, I talk about collapse. This is a typical case of collapse of the maxillary segment. Collapse means that like a constriction becomes smaller. For the palatal repair, especially the pushback operation. The palatoplasty, the closing the palatoplasty, the tissue in the hard palate is dissected and then moved to the lateral position as in pushback. So the palatal bone become like a naked. And then after that, the contraction occurs. So with the scar contractions of the minor segment, all teeth are moved to the palatal side. This is a typical collapse of the maxillary segment. This shows orthodontic treatment. For skeletal problems, the orthodontist performed mandibular protrusion using a chin cap appliance, maxillary advancement using a maxillary protractive appliance, MPA, and not destruction and orthogenesis or orthodontic surgery. And for dental problems, the orthodontist used the expansion, performed the expansion or collapsed dental arch because dental arch is narrowed using a lingual arch or active plate appliance, and the movement of adjacent tooth combining secondary bone graft and orthodontic treatment. And third is tooth alignment using a multi-bracket appliances. I explain one by one. This is the mandibular intrusion to protect the growth, anterior growth of the mandible using a chin cap. The power of the elastics restrict for the growth of the mandible. Usually we can use this instrument for a growing year's age, growing the children. This is a maxillary advancement using a maxillary protractor appliance, MPA, which is used for severe maxillary growth disturbance. This is the case with the serious malocclusion and deformity. So in the case of the severe maxillary growth disturbance, we pull the maxilla forward using elastics, MPA appliance. In this patient, the maxilla was put forward by MPA, and you can see the improvement of the crossbite. Maxilla was gradually moved forward, and the mandible also gradually moved backward. And after that, later, the collapsed maxilla was expanded using the fan-time expander or quad helix appliances. Okay, I talk about autogenous bone graft in the alveolar cleft. This is now the key for treatment of malocclusion in patients with cleft lip and palate. In the history of the bone graft, occlusal management of cleft lip and palate, it is said that there are three major eras. The first one is the prosthodontic era from end of 19th century to the middle of 1940s. Malocclusion was treated by prosthodontic treatment solely. In such a case, extract and then only bridge or dentures, malocclusion was treated. And the second stage is orthodontic and prosthodontic era. From the end of 1940s to the 1970s, maxillary growth disease caused by therapy repairs were treated by orthodontic movement, and then completed by the prosthodontic treatment. Many patients are very happy to get beautiful teeth, the white teeth. But after that, the patient complained the periodontitis, also the fracture of the bridge. They have to make a bridge again with an expensive price. The third is the non-prosthodontic challenge. After the 1980s, secondary bone graft combined with orthodontic treatment. So aiming non-prosthodontic management of patient has been challenged. Non-prosthodontic management means perawatan tanpa asap gigi, tidak usah asap gigi. Occlusion was recovered. From timing, the autogenous bone graft and the alveolar cleft is classified in several stages. Primary bone graft at the primary lip repairs. Early bone graft at 1 year of age. Early secondary bone graft at the completion of deciduous teeth alignment before eruption of the permanent teeth. And the secondary bone graft at eruption of the permanent canine or lateral incisors adjacent to the alveolar cleft. And then lateral secondary bone graft at the completion of permanent teeth alignment. In the history of the autogenous bone graft, the primary bone graft was trained in 1960s. In 1958, Dr. Stilmacher from Germany reported the primary bone graft first. And then later, the Carnahan and Rosenstein orthodontists in Chicago Children's Memorial Hospital introduced an early bone graft protocol. This protocol includes the feeding plates and primary lip repair at 6 to 8 weeks, 1.5 and 2 months after birth, a little bit earlier. Alignment of the upper alveolar arch, and then primary lip bone graft. Bone graft is performed 4 to 5 months after birth. And then palatal repairs was carried out 9 months or 1.5 years old. In the 1990s, the primary bone graft was carried out in many institutions in the world. However, it was not continued because of the poor result of the maxillary growth. I just showed the patient treated with primary bone graft at Kyushu University Hospital. Before I moved to Kagoshima University, I was the staff of the Kyushu University, so I saw many cases who had a primary bone graft. The previous Professor Fujino, he was one of the pioneers of the cleft surgery in Japan, and he had challenged the primary bone graft. 56 patients underwent primary bone graft during 1963 to 1969. And then they are recalled, and 80 patients responded. So this is a patient with UCLP, received primary lip bone graft, and then returned to the hospital 28 years later after he became an adult. On the radiographic examination, we cannot find the graft bone in the alveolar cleft. In one patient, this is the occlusion at 20 years old of age. Alveolar cleft remain, and the bilateral upper central incisor was severely dislocated. It's a little bit old case. in 1993. And orthodontist Dr. Suzuki assessed the cranio-maxillofacial morphology of patients treated with primary bone graft and while comparing the patient without bone graft. The subject with the primary bone graft is 18, 8 men and 10 female. And age and sex matched patients without bone graft is 36, 19 male and 17 female. So you can see the cephalogram. The comparison of facial profiles between the patient with without primary bone graft and healthy subject. The solid line is the primary bone graft, patient with bone graft. The broken line is the patient without bone graft, but both are CLP. And then the dotted line, the healthy subject. So you can see the solid line, the patient we treated with the primary bone graft had the most serious maxillary growth disturbance in male and female. So this indicates that primary bone graft impaired maxillary growth in patients with SLP. This is a comparison of the facial profile with almost like a normal occlusion in UCLP patients, and then cross bites, but in UCLP patient and healthy subject. The both cross bite and no normal occlusion in UCLP patients is almost same. That means even they are different in the occlusion, their maxillary growth was very poor. So the primary bone graft restricted the maxillary growth, connecting the maxillary segment by the hard tissue. I think the bone did not grow. So after that, we stopped using primary bone graft. And then so after that, we performed the secondary bone graft. The secondary bone graft is the bone graft just before the eruption of the permanent upper canine or lateral incisor. The purpose include stabilization of the maxillary segment that are expanded by the expander and enable the orthodontic movement of the teeth into the alveolar cleft space, resulting in the non-prosthodontic treatment. Occlusal management is done without prosthodontic treatment. And the closure of the oral nasal fistula, the support of osseointegrated implants, and the improvement of soft tissue deformity at nasal RBs. They have several benefits and purpose. This is a schematic demonstration of surgical procedures for the bone graft. The mucoepithelial flap lining alveolar cleft is cut and then elevated to the nasal cavity and then oral cavity, oral side. And then the sutures. These are recipient space. In this space, autogenous bone and marrow is filled. And then after that, grafted bone is covered by sufficient advanced periosteal flap. This is scenery during the operation, autogenous bone and cancerous bone and marrow. And mucopelvis flap is elevated, and the nasal floor is sutured and closed. This is the space for the alveolar cleft. In this space, autogenous cancerous bone and marrow is filled. The bone graft should be made until the same level, height of the canine's root apex. Okay. We don't use the cortical bone and or like a brook bone because the space remain, right? like cancerous bone and marrow taken from the iliac crest. It has a high ability of new bone formation, so and it's soft. And after the operation, as low possibility of infection. This showed the careful, successful orthodontic movement of the upper canine into the alveolar space. You can see there's no more space in the alveolar graft. After the secondary bone graft, orthodontic movement of upper canine into the alveolar space is performed by orthodontists. This is you say A patients, and secondly, a lateral incisor is missed. But after bone graft, the canine is moved, and then almost the shape, same as the healthy subject as obtained. The goal is to recover the good occlusion functionally and aesthetically in the same level as the non-cleft subject. When the patient is adult, dental implants are used for occlusive treatment. And also integrated implant was also inserted. After the bone graft, also integrated implant can be inserted. And then after that, the prosthodontists make a ceramic crown. And without the grinding the teeth, we can produce a good occlusion in a patient with cleft lip palate. Now I show the flow of the orthodontic treatment for patients with LP. You can see the face just after birth, and then 1 year after birth. She has very wide cleft. I showed it before. At 5 years of age, the depression of the mid-face was recognized. And then orthodontists start the MPA treatment. The oral view, she had an anterior crossbite and also lateral crossbite. And then slight maxillary collapse and the deviation of the lateral deciduous, lateral upper incisor was deviated to the palatal side. And then we use the maxillary advancement using a NAM, maxillary protractive appliance. She used this appliance during staying home and sleeping. She wears like a frame type face mask. And then MPA fixed with the lingual arch. This is pulled by elastics. It is said that utilization of MPA for more than 14 hours is effective. In this patient, she used MPA every day, at least 10 hours a day for almost 5 years. It's very long, but she is very cooperative. In this patient, the maxilla was moved forward gradually. You can see the improvement of the crossbite. When she was 10 years of age, there's no crossbite anymore. And then rotation of the upper central incisor was improved by the lingual arch by the orthodontist. You can see the palatal side. And then after that, we performed the secondary bone graft when she was 10 years of age. You can see the newly formed alveolar ridge. And then upper canine elapsed inside the grafted bone. And the orthodontist moved the upper canine by the elastics. This showed before and after bone graft and orthodontic movement. But actually, the upper incisor was elapsed automatically after bone graft. The alveolar cleft has already filled by the newborn. And then this is the upper canine was elopted in the adequate place. She is now 13 years old. She's still on the orthodontic treatment, not finished, but you can see the good occlusion with sufficient overjet. You understand that using the secondary bone graft and orthodontic treatment, the patient occlusion is recovered to the level as the same level as the healthy subject without any prosthodontic treatment. So we also then, she and the families are very happy to see her a smile and good occlusion. I also showed the patient treated by bone graft in Harapankita Hospital. This is a case with very wide, complete UCLP. I treated, operated 1995 September. And then this showed that she was 19 years old. Her lip and nose form are very nice without conspicuous scars. Oh, wait. You can see. And Dr. Suban, how it is right? I already returned to the original one. You can see. That's right?
No.
No? Wait. I'm sorry. Kyoyuka.
Yeah, it's out now.
Hmm?
It appeared now already.
How about now?
Yes, already.
You can see this right?
Yeah, it's right.
Okay.
Okay, Sensei.
Yeah. She had received a bone graft by an oral surgeon, Dr. Shafruddin, and upper canine elapsed in the alveolar graft. The growth of the maxilla was quite good, and then good occlusion was obtained without any prosthodontic treatment. You can see her smiling, it shining. Oh, a little bit moved. Sorry. Indonesia, when the secondary bone graft and orthodontic treatment is combined, you can manage the malocclusion of patient without as these patients. Next case is also a patient with very wide complete UCLP. She underwent primary lip repairs in 1995. After the operation, my lip and nose form is not sufficient, but still the deformity remained. And like she was 18 years old. And so the nose deformity remained, but the lip and nose form seems acceptable. For 18 years, her occlusion was managed by orthodontist, Dr. Inge. This is her final occlusion. The upper incisor was filled by the orthodontist, dentist, but her occlusion must recover very well. I like to see her smile. So I feel like this is our goal. Senyum dan sehat anak Indonesia. Dr. Suban, how long I have a time?
Dr. Suban?
30 minutes more I have. It's okay?
Yes, It should be okay.
Okay.
Prof.
13:15 ですね。I have time ね。30 minutes more ね。
Okay.
Yeah.
Yeah, it should be all right.
Next, I talk about orthodontic surgery ね。And not all patients with creative palate can be treated by orthodontic treatment alone. If the skeletal deformity is significant, we have to treat surgically. So orthodontic surgery is jaw surgery that corrects skeletal deformities and aligns a relationship between the maxilla and mandible. The surgery can improve appearance, chewing, speaking, and breathing function. So the patient's appearance may be dramatically changed, but unexpected complication also can occur in any orthodontic procedure. You have to remind this. So this is internet news in Japan. The title is Medical Error to 200 million yen compensation after surgery for jaw deformity, like orthodontic surgery. A 20-year-old man became unconscious and human visitable. The post-operative airway obstruction caused hypoxic encephalopathy, hand. A terrible accident for young healthy patients. But I'm surprised to see this news describing the same complication occurs in multiple patients and the same surgeon in this hospital. He is a very famous oral surgeon in Japan. The surgeons should be careful to minimize the risk of complication by understanding the specific anatomy and preoperative planning. So the orthodontic surgery to avoiding complication is most important. This slide shows the simple flow of the orthodontic and orthodontic surgery. Patient come with a chief complaint or crossbite or deviation of the tooth. We analyze occlusal model and the cephalograms, and the surgical treatment plan is made in a joint conference with orthodontist and oral surgeon. And then preoperative orthodontic treatment needs 1 or 2 years to make like an occlusal plane, flatten the occlusal plane. And then we perform the orthodontic surgery to improve the occlusion. And after that, post-operative orthodontic treatment is necessary for 1.5 years. And then we've obtained the final occlusion. In Japan, the treatment fee for the orthodontic treatment and orthodontic surgery is covered national insurance in patients with creative palate. So the most of the creative patients can receive the orthodontic treatment and also the orthodontic surgery. That's different from the system in Indonesia. I explain the treatment step by step. The common chief complaint patient is mandibular prognathis and debust occlusion, sometimes incline the lower anterior teeth. And then intraocclusal examination, and we check the crossbite and then crowding of the teeth. We take a cephalo lateral X-ray and then from the lateral cephalograms. So we know the large SNB and the small ANB, we make diagnosis mandibular skeletal prognatism, skeletal class 3. And then we then determine the direction, the amount of the jaw movement during the surgery. They're using like a cephalogram, a paper surgery, and CAS model, like a model surgery. In this case, to improve the angle SNB from 86 to 79, and almost same as the average of the Japanese adult. Then we decide the 13.5 millimeter is necessary for setback of the mandible. After determining the operation method, we perform the computer-aided surgical simulation using simple software. The 3D CT is used to demonstrate the jaw morphology. By surgical simulation, we separate the mandibular ramus and we check whether the space, there remain the large space during the bone segments and any excessive interference between the segments. When we perform the simulation surgery, we also simulate the future appearance. Soft tissue simulation is also useful to create a predicted facial features. We move the mandible for 13 millimeter, and then after that, in this case, lateral profile has improved. The surgeon and the patient can confirm the facial profile improved to the adequate form. Next, I talk about surgery. In our department, we use mainly 3 operations: sagittal split ramus osteotomy, SSRO, and the intra-oral vertical ramus osteotomy, IVRO. And they are commonly used for the mandible, and for one osteotomy for the maxilla, a horizontal cutting of maxilla. First, I talk SSRO. The sagittal split ramus osteotomy is probably the most frequently used in the world for correction of the mandibular deformity, because this operation has wide indications like a mandibular setback in push lateral position of the mandible, and the mandibular advancement, forward movement of the mandible, and then correction of the asymmetry, and the anterior crossbite. In this operation, the outer cortical bone of the bilateral ramus is divided into the sagittal section, and the inner bone segments are moved anteriorly and posteriorly. This schema shows the SSRO like a Dalpon-Obgeza method. The mandibular ramus is separated from the mandibular first molar to the mandibular foramen. A mandibular nerve is included in the inner bone. This operation has several advantages, like a bone contact area. After moving the mandible, the bone contact area is wide, so the relapse is not often. And all steps approach, it can be done from the oral cavity. There's no scar, wound in the outside of the face. And relatively safe techniques and wide indication for various mandibular deformity, as I mentioned before. On the other hand, disadvantages include possible damage to the inferior alveolar nerve. Inferior alveolar nerve is exposed in the operating view. Even we don't cut, we don't injure the inferior alveolar nerve, and sometimes patients complain the hypoplasia, hypoesthesia of the mental area. And then TMJ symptom may occur. One more operation for the mandibular operation setback is the intraoral vertical ramus osteotomy, IVRO. It is called Robinson techniques. In this method, posterior part of the mandible ramus, including condylar head, is separated vertically using like a saw, and then the small contact area. This is only a small contact area. So the advantage of this method is very simple and easy. And then no need to fix the bones. And there are a few TMJ symptoms. It is said that. And then also low probability of nerve damage, because if inferior alveolar nerve is not exposed during the operation. But the disadvantage is the high relapse rate in patients with open bite or CLP. So it is said that from the perspective of the orthodontist, the post-operative jaw position following the IVIO is unstable. I forget IVRO. I lost I. Okay, I just explained our SSRO briefly. The incision line is made at the front of the mandibular ramus, and the dissection area is a little bit wide, soft tissues, and the buccal area is dissected completely. And then inguinal side, only a mandibular notch to the mandibular foramen are dissected. It is important to have a visual view around the mandibular foramen to avoid the injury of the vessels. We must not damage the periosteum behind the mandibular ramus, because there is a little mandibular vein. If you damage this vein, it is quite difficult to stop bleeding. We performed osteotomy using obligato method. For bone cutting, we use the reciprocating saw for the lingual side and Lindemann bar or round bar for buccal side. During the bone cutting, we use the retractor to avoid the injury of the mandibular nerve and vessels. And the bone is splitted using a bone chisel. We have to take care of the unfavorable bone fracture during the bone splitting. After we obtain adequate occlusion by intermaxillary fixation, the bone segments are fixed using titanium mini plates. This is a 25-year-old female. She is not a acute patient with skeletal class 3 who underwent SSRO with 30mm setback. Before, her face is a little concave, and she complained crossbite. After the operation, protrusion of maxilla and anterior crossbite was improved. She had a good lateral profile after the operation. Next, I talk about the 4-1 osteotomy. This is one of the most common procedures for the mid-face deformity. In this method, maxilla is cut horizontally and allow the three-dimensional movement, advancing like protrusion and elongation and shortened. And the combination of 4-1 surgery and mandibular setback is often used for patients with creative palate. I showed surgical steps. Usually, the mucosal incision connect between the zygomatic buttress, but in case of the creative palate, the mucosa on anterior palate is not separated. Only lateral parts are inside. The osteotomy began placing the bar or the surgical saw at the piriform aperture and extended through the lateral maxillary wall until the zygomatic buttress. To avoid damage to the tooth root, we cut at least 5 mm above the apex of the roots of the upper teeth. This is down fracture. The down fracture is made from the bottom of piriform aperture toward the zygomatic buttress using the bone spreader. We also use the low forceps to avoid abnormal fracture, and also for mobilizing the maxilla. Low forceps is useful to hold by two hands, right and left symmetrically. And then complete down fracture allow the complete visualization of the descending parietal artery. That is very important for the blood supply of the maxillary bone. The maxillary segment is only governed by the descending parietal artery. If we injure this artery, we are afraid to make a necrosis of the maxilla. Next, we're the splint for guiding the ideal occlusion, and the relationship between the upper and lower jaws are determined. And then we fix with the 4 titanium mini plates. Usually we use L-shaped titanium mini plates. And then sutured. That's the end of the operation. This is a case of 20-year-old man with a skeletal class 3 with a big anti-crossbite and protrusion of the chin. We performed the for one surgery and mandibular setback to move the upper jaw 4 mm advanced forwardly, and then set back of the mandible to 7 mm by bilateral SSR load. After the operation, his lateral profile was improved and chin protrusion was, the crossbite was improved successfully. This is a case, the patient who was used LP. You can see the concave in the facial profile and protruded mandible. And before treatment, he has serious crowding and big anterior crossbite. And then after the Lufowan osteotomy and bilateral SSRO, you can see a good lateral profile and good occlusion. After the operation, his lateral profiles have become almost the same level as the healthy subject. We also performed the secondary nose correction, so his nose is well projected. And then this is the final goal of the treatment of the clavicular palate patients. The complications after orthodontic surgery include nerve damage, especially the mandibular nerve, in the case of SSRO. Temporomandibular joint disorders sometimes occurs. Unexpected fracture of the bone. So we have to separate the bone segment carefully. Abnormal bleeding by injuring the big artery and vein. So we have to know the anatomy, and also we have to dissect the soft tissue carefully. Airway obstruction, it's very important. So in the case of two-jaw surgery, like I like for one and SSRO, we manage the patient for one night in the ICU. And one more, the idiopathic condylar resorption, ICR. This is also very famous, right? Last, I talk about the destruction of osteogenesis briefly. This is a method of pulling the maxilla forward and stretching the jaw and soft tissues using the headgear. And after separating the maxilla and mandible, we put the bone gradually using elastic power. And this treatment is indicated for large jaw deformity that cannot be corrected by orthodontic surgery. But recently, intraoral device for destruction osteogenesis is more developed. It has advantage without damage of the head skin. However, there is a limitations of the stretching amount and the stretching direction. We usually use such a device like expander of the orthodontic treatment. The stretching amount is limited. I showed one case whom I treated with destruction techniques. He is a boy with Gardner syndrome. And then he's like a macrostomia, like a transverse cleft, was already treated, operated in a baby foot. He's 11 years old, and then he complained the facial deformity and occlusal plane inclination due to the hypoplasia of the left zygoma and the mandibular ramus. You can see the small condylar head on the left side because the Gardner syndrome has a hemifacial microsomia. At the age of 12, we performed our destruction osteogenesis in the left mandibular ramus. We surgically cut at the base of the lateral condylar head, and we applied extraoral devices from the submandibular area. Mandibular ramus was extended by 1 millimeter a day for 26 days. Totally, the 26 millimeter was expanded using this device. And then, so this device was embedded for 6 months in his skin. Then you can see new bone formations after 6 months of the destruction of osteogenesis. And then we removed this device. The left show the face and occlusion just after this destruction of osteogenesis. The mandible rotated to the medial side. Actually, we need more, but 26 millimeter is the upper limit of the device. And then the space in the mandibular molar area is created because of the elongation of the mandibular ramus. After that, orthodontists pull down the maxillary teeth. And then so she complained about his facial asymmetry. So we performed the facial improvement by free graft or the free dermal and fat graft from the abdomen. From the abdomen, we take us fat and skin and then put inside the buccal area. These are the facial view and occlusion after destruction of osteogenesis and orthodontic treatment for almost 1 year. The inclination of the occlusal plane was improved. The last facial view was a little bit different between right and left side because left side is still small, but the frontal view of the face become symmetrical. You can see the good occlusion after destruction of the mandible. So the orthodontic surgery and bone graft is a little bit difficult for like a small boy, but to extend to stretching the bone tissue, like destruction of osteogenesis is useful in such a case. Okay, this is also my conclusion. In Kagoshima area, we also have several clavicle palate centers managed by the plastic surgeons and without also dentists and oral surgeon. But many patients come to our dental hospital for requiring a complete team care, including surgery, speech management, and orthodontic management. A comprehensive team approach involving various professionals allows the patient to lead a smooth social life without serious problem. So today, I hope you understand that dentist jobs in the treatment of clavicle palate is very enormous. Dan tugas Dr. Gigi dalam perawatan CLP dan bibir langit-langit sangat besar. I hope you understand. You enjoy my presentation. This is Kagoshima. Please come to Kagoshima. Kagoshima has beautiful active volcano, Sakurajima, the mountain, active volcano floating on the sea. It's very beautiful in the summer season. Thank you very much. Terima kasih banyak.
Thank you very much, Professor Nakamura, for your interesting lecture this afternoon. So I would like to open the discussion session for the second session. Please, if you have any question to Professor Nakamura about his lecture today. Is there any question from undergraduate student first? Bahasa Indonesia juga bisa. Profesor Nakamura bisa jawab dengan bahasa Indonesia.
Aneh deh. Saya coba pakai.
Yeah. Any question? Please.
Selamat siang, Dr. Subhan.
Yeah, please. From Dr. Nico, please.
Oh, nice to see you.
Konnichiwa, Nakamura Sensei.
Kamu sudah dapat kumisnya? Kelihatannya dewasa deh.
Ya, perkenalkan nama saya Nico dari from resident oral maxillofacial surgery. Yeah. My question is, when the ideal time to use NAM or similar appliance? As we know that the older the baby, the more difficult for them to make an adaptation.
Yes.
If the baby get older and they won't accept the appliance, what should we do? And then the second question is, after the palatoplasty, the post-operative scar can make the alveolar arc of the maxillary bone collapse. And after the orthodontic treatment, is there any possibility for the bone to back collapse again?
Final sentence.
Recollapse. Recollapse after the orthodontic treatment.
Oh yes. Thank you for your question. The first you asked about the timing of NAM or like a orthopedic, right? I think it's so as area is the better. Area is the better because the maxilla is soft and also nasal connection is not hard. More easily to move during the pre-surgical orthopedic treatment. And also, if the patient become a little bigger, sometimes it's very difficult to accept appliance or appliance to enter the mouth. So if you use to the like a appliance to control the wide deviated maxilla, I recommend you to use more active appliance. You put the plate by like a screw or something and moved. Like a NAM and hot plate is passive appliance. For the like a already grown up the children, it's very difficult to use, I think. All right. And the second question you asked about the possibility of a recollapse. Yeah, that's what occurs. So we need the secondary bone graft to fix the expanded maxilla, and also we have to use the like a retainer for orthodontic treatment. It's more longer. In previously, I saw the one case. He had a serious collapse, and the orthodontist moved the tooth by expanding the teeth. But later, the tooth apex, the tooth root, and the buccal side all exposed from the bone. You know, the orthodontist can move the dent, but sometimes not all bone follow the orthodontic treatment.
Yes, thank you very much.
Think about yes.
Okay, okay, Dr. Nico, is that okay?
Yeah, Dr. Supan. Thank you, Sensei.
Thank you. Thank you.
Okay, thank you very much, Sensei. So we'll go on to the next question. Maybe is there any question? Because since we have another residents from maybe like from orthodontics or from pediatrics dentistry, we also have a participant from that department like from orthodontics. Is there any question?
Yeah, periodontic and orthodontics are very active. Yes, Fenika.
Okay, please.
Mohon izin dokter.
Fania.
Enggak dokter. Can we use bone graft for the baby cleft palate? And if we can use the bone graft, is there any possibilities for the bone graft to get broken by the baby tongue after we use the bone graft for the baby? Thank you.
Yeah, thank you. So during my presentation, I showed the case. I showcase who underwent a primary bone graft in 1990s in the Kyushu University. I previously worked at Kyushu University, and at that hospital, they performed bone graft at the primary stage, like a baby food. You asked about the primary bone graft, right?
That's right.
But unfortunately, the future maxillary growth was very poor because the grafted bone in the alveolar cleft, I think it's did not grow anymore. So the maxillary bone is like tightly and then hold it. And then so after that, maxilla cannot grow anymore. Usually, the primary bone graft is not recommended in the treatment of corrective right now. All right.
Okay, thank you, Sensei.
Okay.
Yeah.
Thank you
And
very much.
one more I have experienced. One lady sent me photos of her breast because when a childhood, the deep bone was taken, but after 20 years later, the scar make a deformity of the mama breast. That she wrote later that please stop such an operation. So we quit the primary bone graft completely. Thank you.
Thank you, Sensei.
Okay, thank you very much.
Thank you.
Is there any question again? Maybe from orthodontic department or pediatric department?
Boleh pakai bahasa Indonesia. Saya harus coba deh.
Ya, boleh. Please, Sensei. Is there any question?
Somebody call you.
Yeah.
Somebody call me, but I cannot hear. Who?
Call the name.
Please, please.
Fascio.
Who? Louder, please. Speak louder. Please go
What's
on
your
to
name?
your question.
Lisa. Nikumatsun. Nafisa. No, Nafisa.
No, not here. Not her. Please, maybe from Prof. David, any comment or any question?
Ya, dalam bahasa Indonesia.
Oh, sure.
Bagus.
Sensei, apa saya mendengar di Kagoshima, rumah sakit Kagoshima, untuk alveolar bone graft tidak harus menggunakan autogenous bone graft, ada bone substitute.
Ya, ada.
Ya.
Ada.
Bisa
namanya,
diceritakan?
Terima kasih. If I had time, I want to introduce you next time. So I use the octacalcium collagen. Ini dibikin di Universitas Tohoku. Kita sudah coba pakai like autogenous or not autogenous, artificial bone substitute.
Bone substitute.
Autogenous. Artificial. Ini tapi dibikin dari babi ya, tapi kolagen. Kita sudah masuk di dalam aloe vera, sesudah 6 bulan, dan tulangnya dibikin, dan gigi canine sudah tumbuh seperti autogenous bone. Sekarang the company is producing like materials in the commercial base, but still they are negotiating to the government of the Ministry of Health to enter the national insurance, because most of the patient is baby. Without national insurance, they cannot use. So it takes time, but maybe 1 or 2 years later, we can use. And then I suggest the company, don't use the baby.
Yeah.
Because in the strategy on the world market, they should use a different kind of animal.
Yeah.
Kalau collagen dari babi, orang Muslim tidak bisa pakai kan?
Tidak bisa pakai. Nanti tidak laku di sini.
Ya, betul.
Ya, kamu harus bikin dari cow.
Dari cow, ya.
Cow, ya.
Sapi.
Sapi, ya.
Bisa bisnis ya.
Okay, thank you very much.
Thank you,
Professor David, for the question, and thank you very much, Prof. Nakamura, for the answer. Is there any question again?
Saya Dr. Suban.
Please, Dr. Mira.
Yang lain dulu aja kalau gitu. Saya terakhir.
Izin Dr. Suban.
Okay.
Go.
Okay, please, Dr. Ghazali. Dr. Peter.
I am Dr. Peter, maxillofacial surgeon. I would like to ask several questions. The first one is all of them is related to orthodontic surgery. Which one you prefer? Surgery first or orthodontic first? That's the first question. The second question is, do you prefer mandible first or maxilla first? And what about the consideration? Both of the questions. Thank you.
Okay. You asked about the steps of the surgery or orthodontic treatment. Yeah, we don't prefer the orthodontic surgery first. Our orthodontist requires more stable results. So the oral case in Kagoshima University is performed orthodontic first. I explain you orthodontics and the operation, and after that we perform the post-operative orthodontic treatment. Is all right? Next question, maxilla first and mandible first. I think usually the maxilla first is more common because the maxilla should be placed in like a more close to the skeleton, cranial. It's more cranial.
More stable.
Right? Yeah, and then so the mandible is still stable. With a stable condition, we move the maxilla by like a to sprint, double sprint. The first sprint, we connect the maxilla, and then after that, we cut mandible. We use the second sprint, double sprint method we use. You understand?
I got it.
Okay. And the last question is regarding what?
The consideration, both of them, but you answered actually, Professor.
Okay.
Okay, thank you very much.
Thank you very much, Professor, for the answer.
Yes.
Okay. Thank you very much, Dr. Peter, for the questions. Next questions, maybe?
Mira.
Ya.
Dr. Mira?
Ya, selamat siang, Nakamura Sensei. Terima kasih.
You have a good sofa.
Ya. Mira Sensei. Di sini kan banyak undergraduate students, Sensei. Apakah Sensei ada pesan nanti kalau mereka sudah lulus bekerja baik di rumah sakit pemerintah maupun di pusat layanan kesehatan masyarakat atau praktek pribadi, kalau misalkan menemukan kasus celah bibir dan langit, apa tahapan yang harus mereka lakukan untuk mempermudah persiapan dan meningkatkan hasil operasi, Sensei?
Susah deh, bahasa Indonesia. You ask when they start walking, maybe you face the problem of the cleft palate patients.
Yeah.
And then so you ask what they should do.
What do you suggest for the young dentist to prepare the preoperative stage to improve the surgery outcome?
Yes, that's true. So the dentist work with the plastic surgeon is okay. Oral surgeon or plastic surgeon, both is okay. If the dentist cooperates to manage the cleft lip and palate in the early stage, I think the result become more better. And also the dentist should take care of the occlusion because most of the patient has crowding, and even they received orthodontic treatment, they have to keep the oral hygiene. I think it's the collaboration in the team of the cleft lip palate. The collaboration of the dentist is very important, I think. Don't hesitate to join the great treatment. That's okay. Okay.
Okay, thank you, Sensei.
Yes, thank you very much, Sensei.
Students ngerti ya?
Another question? Pertanyaan lain?
Saya, Sensei. Izin.
Okay. Please, Dr. Ganendra.
Udah ada fotonya itu, Dr. Ganendra, nggak boleh.
Oh ya, tampakkan wajahmu.
Lah.
Oh, alright.
Hello, Sensei.
Beside you, who are sitting? Your wife?
His wife.
Yeah. Thank you very much for your presentation. Good presentation, Sensei.
Thank you.
Maybe I want to ask you about how to decide to extract the unerupted teeth in cleft palate patient or not? When we decide to extract it, or when we must do what is it? Make an autogenous graft.
Preserve.
Preserve.
Yeah, preserve the
canine.
You asked about unerupted impacted tooth?
Yeah, in cleft palate patient.
Yes. I think it's why the impact. Maybe it's the biggest reason is the loss of bone, right? You have to put the bone, allograft, bone graft, and then you pull down using the orthodontic treatment. Now, of course, if patient can pay for the orthodontic treatment, yeah.
Is this always use autogenous graft or not? To
I never use,
the
yeah, from the lower premolar, I have experience to transport to the correct space after bone graft. If the patient is still young, you can use.
Okay.
Yes.
Okay. Thank you.
Thank you.
Okay, next question maybe from undergraduate students or orthodontic department, pediatric department.
So I can see a big piano.
Big piano. Who is
Nabila.
big piano?
Nanda.
Ah, no. Annette.
Oh, Annette. Oh, Annette.
Annette.
He has me a question.
Annette, please talk. Annette. Annette freezing.
Annette Nabila. She's a musician, Prof. Sensei. She plays piano and violin and what other music instruments?
I also played the angklung.
Yes, that's right. We play angklung. Okay, is there any more question?
From me, Dr. Suban.
Okay, next, please, Dr. Andra.
I know his voice.
I'm not asked for some question, but I want to give some news from the patient that we did the tongue flap.
Oh yes.
Yeah. Now she doing the orthodontic treatment, and then we give her some partial denture for her front anterior teeth, and unfortunately, she refused to do the orthodontic surgery.
Oh,
she's afraid.
Yeah.
Because of the surgery.
Yeah, but you have to.
Yeah.
You have to talk to her.
Yeah, we talk so many, but I think she had enough for a lot of surgery. I think the tired sensing. And
she is very active, right? Active.
Yes, of course. Of course. She's very active and
students in the UNER, right?
Yeah, UNER and the other private university, I think. Yeah. And until now, she's very happy.
Thank you very much.
Thank you.
Yeah, I'm very happy to hear it.
Yes.
Thank you.
Happy.
Yeah. Reza, thank you,
One
Reza.
more question, Dr. Suban.
Reza, she cut tongue, right? He cut the tongue.
Yes.
Yeah, Dr. Mira. Dr. Mira cut the tongue.
Dr. Mira.
Dr. Mira.
The first patient, I cut the tongue. The younger patient.
David, maybe you have a question.
Yes, I have one more question.
Yes.
You said that in dental hospital, Kagoshima University Hospital, with better attended CLP clinic, CLP clinic compared to the plastic CLP center? In what sense that it is better, and what makes it better than the other side?
But actually, the labioplasty and the nose correction by plastic surgeon is also good. Yeah. We are both our surgeon. Yeah. But for management the cleft and palate patients, the problem is not only the aesthetic. The more functional the aspect is more bigger. And then to support the patients psychosomatically, it's patient and parents is very important. So after the baby born in Kagoshima, we visit the obstetrician in the same day. And then so they believe they are very happy to have help from the medical staff. So we make a good like a connection with the parents and medical staff. So the early contact for the treatment of cleft lip and palate is one of the most important things.
The early service, the service that is given after the baby is born.
Yeah, especially between the nurse in the dental clinic and oral surgery and the nurse of the like obstetrician and the nurse, they exchange the information to care the babies. That is very important. You have to include the nurse job.
Yeah.
Thank you. Thank you very much, Professor Nakamura and Professor David.
Thank you.
We already have limited time, so we already come to the end of the time for this session. So we need to close this interactive communication and question and answer, because I believe there is still many more to ask you, because we already miss you also, Sensei, because we like to rindu. Rindu, Sensei. So for the closing, Professor Nakamura already showed us the comprehensive management of CLP from the newborn to the final goal into the social life, a good social life for the patient. And dentists have an enormous role in CLP, right? So from the pedodontics, orthodontics, oral maxillofacial surgeon, and also general dentists also have an enormous role, because if you work in the rural area, you can learn from this session what you have to do to how can I say, to join to participate in the management of cleft lip and palate. So thank you very much, Professor Nakamura, for the very interesting lesson today. Thank you very much for the committee, for the official of the Dakota program and Stovit online series. Thank you very much for Professor David and another senior like Dr. Mira, Dr. Ganendra, and maybe from the other department, there is I saw Prof. Talka, maybe. Is there any Prof. Talka? Yeah. And other seniors that I cannot mention one by one. Thank you for today. I hope we can join another meeting, another webinar with another topic. Thank you very much. Good day. Terima kasih.
Thank you very much, Sensei.
Thank you, Dr. Kuri.
Bye-bye. I see you.
Thank you, Dr. Kuri.
Hope you are in good health.
Thank you. See you again.
Sehat-sehat. Sehat-sehat, Sensei.
Healthy.
Yeah.
Bye-bye.
I miss you.
Thank you.
See you, Sensei.
See you in
Thank you, Irma.
Please send best to the Professor Kuhn.
Yes, okay.
Yes.
Yeah, thank you. Bye.
Thank you. Bye-bye.
Bye-bye, Sensei. Nice to see you.
Terima kasih Dr. Tubai.
Ahmed.
Thank
Ya,
you, Dr. Irma.
Ya, thank you, Dr. David. Bebas. Terima kasih mahasiswa juga semua.
Terima kasih mahasiswa juga.
Saya
Terima
izin
kasih
nih.
ya. Ya, see you. Bye.
Bye-bye, Sensei.
Bye-bye.
Okay, I go out from the.
Yes, thank you very much, Sensei.
Bye, bye. See you.
Thank you.
はい、お疲れ様でした。
お疲れ様でした。ありがとうございます。
ありがとうございました。
Terima kasih, Dr. Irma. Terima kasih.
Sama-sama.
Terima kasih, Prof. Saya izin live.
Ya, saya juga live.
Ya.
Masih semuanya.
Terima kasih, Dr. Irma. Nanti saya laporan. Terima kasih.